spine division surgery in the Department of Orthopedic Surgery, adjunct faculty within Duke Global Health Institute. He has a doctor in chiropractic and a PhD in public health, and is interested in improving the field of non-operative spine care. So today he's going to talk to us a little bit about his global health interests and his background, and kind of shining a light on non-operative back pain care. So with that, let me share my screen, and then I'll just give you my laptop.
Okay.
You can advance. That might be easiest.
Okay, thank you.
Yeah. I can move to it. Oh, I can just pass it over. Yeah.
Okay.
Awesome. Cool.
Well, thanks, Anna.
You're welcome. Take it away.
Appreciate it. Everybody see/hear me okay? I have the sun behind me. It's a beautiful day this morning, but it does make me look a little shadowed, but hopefully it's okay. Yeah, so grateful to be here. I have honestly kind of aspired to this type of opportunity for a long time. As Anna mentioned, my PhD is in public health. I got that from the Medical College of Wisconsin. And my project was in Nigeria, looking at road traffic injuries, and we did a geospatial analysis of hotspots in Abuja, and it was an incredible opportunity, and I loved it. And I am, as Anna mentioned, a chiropractor, so most of what I do is clinical care. And so the opportunity to
Later.
okay,
Yeah,
thanks.
you don't want to. Thanks.
So the opportunity to be part of the DGHI is just honestly a dream come true for me. So thanks, everybody. Grateful to be here. And I'm hoping that what I share today is more conversational and less kind of lecture oriented. The first part of what I want to share is definitely kind of just sharing data and kind of lecture. But I hope, my hope and my goal after this is to come away with some better ideas of how to move forward against an issue that we're seeing in global health. I have a unique background as a chiropractor. What I love about these types of settings is that we pull from wisdom and savvy from all sorts of different fields, and we have this opportunity and this space to kind of talk to flesh out ideas about issues. This is one of them. So anyway, looking forward to this. Okay, so just to kind of let's see. Should I hit return on this?
No. Try clicking back on the slide again.
Okay,
and then it should go.
there we go. So I have no financial relationships here. AI was not used in creating this presentation. I do have to, in my disclosures, however, let you know that I am a chiropractor. So I definitely have a bias towards back pain. I see it every single day in practice. Have seen it globally. And anyway, so you'll see that throughout this presentation. So the title of my presentation does actually kind of beg a question, and that is low back pain actually a rising problem? So just some data to kind of begin with here. Short answer is yes. So it is actually, and this may surprise some of you, it's actually the largest cause of disability globally. With 60.1 million disability adjusted life years in 2015, that's a 54% increase since 1990. And the largest increases we're seeing currently are in low and middle income countries. The biggest population affected by low back pain is the working age population. That's concerning for lots of reasons, but specifically in LMICs, where informal employment is a lot more common, then individuals who injure their backs may not be able to, and probably won't be able to receive any medical leave support. Opportunities or options for job modification are limited, even when it's a formal employment position in LMICs. Those are limited benefits. So either they have to work with debilitating back pain or not get paid. So what's the prognosis? What's the forecast? By 2050, we expect to see an increase in low back pain cases by 36%, which at that stage would probably be affecting approximately 843 million individuals. I should mention too, this isn't like your back aches. Like everybody gets that. This is back pain so bad that you're going to go seek medical care for it. So bad that you won't go to work because you can't work because your back pain is not allowing you to stand or walk. Again, I think sometimes when we talk about back pain, it's easy to kind of say, oh, well, it's like not a huge deal. It's not killing people. But when we look at disability adjusted life years, there's nothing that's worse. Or years lived with disability. Again, low back pain is the #1 cause of years lived with disability globally. So we're not talking just about achy backs. We're talking about like really, really bad pain that's keeping people from living life. The greatest increases we expect to see by 2050 are in Africa and Asia. This is just a graphic from a study that was published in Lancet Rheumatology, again, kind of forecasting back pain in 2050. Sorry, the print's kind of small here. Let me just kind of go through. You can at least see the colors. So what they're looking at, the yellow is the change due to changes in prevalence rate of back pain. The lighter green is change due to population growth. The darker green is change due to population aging. And the black dot is the total percentage change. So if we look at the top 3 areas affected by lower back pain, expected to be affected by lower back pain in 2050, #1 is Eastern Sub-Saharan Africa, #2, Western Sub-Saharan Africa, and #3, Central Sub-Saharan Africa. So one of the issues with lower back pain that's making it such a problem, a rising problem, is the etiology. If we just look at it from a pathological standpoint, as ridiculous as this may sound, there are lots of question marks as to what's even causing back pain, which is ridiculous, right? So in my field, we kind of separate back pain into 2 different types. There's non-specific back pain and there's specific low back pain. So specific low back pain is basically stuff that you can find evidence of a cause or an etiology objectively. So if you do a blood test and it looks like somebody has psoriatic arthritis and they have back pain, that would be considered a specific lower back pain. If you do an MRI and you see a bone infection or you see cancer that's having an effect on the bone, weakening bone mineral density, then that's another specific cause of lower back pain. Unfortunately, 85% of all low back pain is what we call non-specific. We can't do an MRI and see the cause of someone's back pain. We can't do a blood test and see what's causing their back pain. They have back pain. It's not letting them work. It's not letting them, et cetera, et cetera. But there's a lot of question marks as far as like where that's actually coming from. So from a pathological standpoint, we have some issues in terms of just the etiology, but also sociologically. I'm sure lots of you are familiar with the term a wicked problem. That's a problem that's incredibly complex, that's intertwined with all sorts of different factors that sometimes when you try to address one factor, it actually has a negative impact on another factor. So meaning that sometimes with the wicked problem, solutions can be worse than the actual problem itself. And lower back pain definitely fits sociologically within that realm of being a wicked problem. So hopefully I've convinced you that this actually is a problem and it will be a problem by 2050 in some of the areas that we have relationships with and that we live in. And so the next question, oh, sorry, before I get to the next question, let me just kind of break down one other aspect of this rising problem, and that's cost. So when we look at cost of low back pain, we essentially typically separate or dichotomize types of cost into direct and indirect costs. So direct cost would be how much it costs to get it treated. So here in the US, that would be seeing a chiropractor, seeing a physical therapist, massage therapist, acupuncturist. That would be potentially getting injections, imaging, surgery. Those are all direct costs of lower back pain. Indirect costs are like opportunity costs. So things that like absenteeism from work, how much does that quote unquote cost you because of your back? Or lack of productivity, how much does that cost you? How much does that cost the community because you aren't being productive because of your back? Relationships, how does that affect our relationships with our loved ones? So those are all examples of indirect costs of lower back pain. Some of those you can quantify, and sometimes some are just a lot harder to quantify. So if we look at the US numbers, and this is obviously, there has to be a large spectrum, and you're like, it's hard to put numbers on everything. Like you can't put a number, for instance, on how someone's relationship is affected by their back pain. But the things we can put numbers on, we think that back pain costs basically between 560 and $635 billion per year. To put that against or to put that into a different perspective, if we look at the cost of heart disease, obviously a huge problem in the US, cancer, diabetes, those are all less costly than managing lower back pain. Part of that is because in the US, which is one of the costliest places to have back pain, we have a very medically intensive approach. So people with back pain frequently will seek care. Sometimes that care ends up being really expensive because imaging is taken, sometimes needlessly. Injections are given, sometimes needlessly. Surgeries, we have the highest rates of surgery for lower back pain in the world. So super, super expensive in the US. But even in LMICs, on average, it's $2.2 billion per year. So less expensive than in the US, but definitely expensive. And given the numbers that we are forecasting in terms of prevalence, will probably become more expensive as time moves on. Just a quick kind of interesting note. So before I came to Duke about a year and a half ago, I worked at Mayo Clinic, and some colleagues and I did a study there where we just looked at the refugees that were seeking care at Mayo Clinic for back pain and whether that diagnosis of lower back pain was predictive of work absenteeism. And it wasn't in that population, indicating maybe that that's less of a cause of absenteeism in LMICs than it is in the US. In any case, now to the question, what do we do? So what do we do about this problem? And this is where I want to involve more of you. Like I have some ideas and I'm really happy to share those, but my ideas are very minimal. Like I want to understand this better, and I'm hoping that we can kind of collaborate for a few minutes here to discuss this. Before I jump in that, one more question that I do have a really good answer to, and that's what don't we do? So what we don't do, I can give you that answer in one word: export. So that unfortunately is the answer that we give to what do we do in a lot of global health situations. And I think it's human nature to see, and this sounds so terrible, but we see someone that we would consider to be quote unquote less fortunate. And we say, I'm so fortunate. How can I make them more like me? How can I make them more fortunate? I know, I just need to export what makes me so fortunate and give it to them. And that's like a really, really bad model that we've seen for centuries. And unfortunately, there are those who believe that we need to take our state-of-the-art spinal care system in the US and export it abroad. And that is a really bad idea. And I'm not the only one saying that. So this is a study published in The Lancet. The author said, in high-income countries, the concern is that the prevalent healthcare approaches for low back pain contribute to the overall burden and cost rather than reducing it. Spreading high-cost healthcare models to low-income and middle-income countries will compound rather than alleviate the burden. Another separate study published in The Lancet, this I thought was really good. The authors come up with something called the low back pain paradox. And the paradox is that as middle and lower income countries improve social and economic conditions, this could prevent or reduce the incidence of lower back pain, but also could create expectations and demands for medical investigations and low-value healthcare that paradoxically increase the risk of long-term back-related disability. That's what we term the low back pain paradox. So what don't we do? We don't export. What do we do? I love how these authors framed what we do. They didn't give answers to what do we do, but they gave a framework. Although there are several global initiatives to address the global burden of low back pain as a public health problem, there is a need to identify cost-effective and context-specific strategies for managing low back pain to mitigate the consequences of the current and projected future burden. So for the rest of this quote unquote talk, which is hopefully going to be more of a discussion now, I would like to kind of frame our conversation in those two terms: cost effective and context specific. So what do we do to address this wicked problem of lower back pain and make care more cost effective? Again, I have some ideas, and I do have a few more slides that I can share about being cost effective and context specific and ways of moving forward. But before I move on, if anyone has some ideas or questions, I think this would be a good time to kind of start discussing those things. If there aren't any, I'm happy to just kind of go right through to some of my own ideas. But what are thoughts? Anyone that's here or anyone that's online with us? How can we make lower back pain care more cost effective and therefore hopefully less of a problem than what we're forecasting for 2050. Carl.
Go for it, Carl.
So I absolutely have to say that I'm in love with the fact that you're bringing this to us right now, because I'm someone who has suffered massively from back pain. I ended up leaving the military because I broke my back. I'm in physical therapy twice a week because of back pain, posture related issues, gait related issues, walking issues, sitting issues, holding my head up issues. Like it's all over the place. Like I refuse to take painkillers because I can't function, which puts me in a predicament where I'm miserable most of the time. But to come at a cost-effective issue, I think one of my biggest things that I've encountered is just getting initial treatment. A lot of physicians put it off, doing any of the proper diagnostic stuff. Like for me to get an MRI in the military, it literally took 3 years. And as soon as they looked at the MRI, they're like, oh, we got to do another one because there's stuff here that stands out and we need something really specific. And then that didn't even come for another 2 years. And now I'm, 6 years post injury and things have healed and they haven't healed properly. And my physical therapist and my primary care physician have no idea what to do because like they joked with me that the only way to heal me is to break my back again and then readjust everything. So, I think the cost effective issue is reducing the time frame to actual diagnostic procedures, getting people trained up so that when a patient comes in and says, "Hey, I hurt here," they're like, "Okay, instantly MRI, instantly looking at the very specific things that could have been the root causes, and potentially referring to a specialist a lot quicker." I know military doctors are horrible about putting off decisions, and a little bit decision paralysis, a little bit lack of training probably, but the context specific side of it is, you don't know unless you've actually treated someone like that or have been injured like that yourself. So getting them onto the next level of care, I think more efficiently and quickly is probably the best answer in a lot of circumstances.
That's really helpful, Carl, and that definitely aligns with some things that I'll bring up as well. Someone mentioned in the comments also strengthening primary care, which I think goes along with what you're saying there, Carl, in terms of like getting people, the right patient to the right provider at the right time. And so yeah, great comments. Thank you for sharing those, and thank you for the comment about primary care and family care. We'll get into that as well. I saw another hand.
Yeah,
Sean?
well, Victor.
Okay, I have an idea here, but I don't know, like it's too obvious, but like the most cost-effective way I think would be prevention, doing like exercise to decrease the possibility of you developing back pain, but like to develop it in a low income and even middle income countries, you would need like some infrastructure to build some free free gyms, nothing like complex. We have some of those here in Brazil, but at least in my experience, it's not people don't use those a lot. So you still have to do that. People have to need time to exercise. So like there's a lot of things related to infrastructure, to policy, to economy that I don't know if it would work, if we can do something about it.
I love that comment. There's an old saying that an ounce of prevention is worth a pound of cure. And that is 100% true when it comes to back pain. Really good. And Carl, bring back school PE.
Yeah.
Absolutely.
For more reasons than one, yeah.
Yeah. So really great comments. Thank you, João. Definitely appreciate that insight. Yeah, that's something I haven't addressed as much in this presentation, but you're 100% right. And I think any broad spectrum approach to managing this issue has to involve a preventative arm. So thank you. Any other comments or thoughts? Kind of aligning with what we've talked about so far. So what we've done at Duke, so about nearly a decade ago, Duke Health, which is who employs me, recognizing that there is an issue with how costly spine care is, asked somebody to come in and develop a different model that was more cost effective for managing back pain. That's actually one of the reasons I got a job here is they wanted people like chiropractors and others to come in and play kind of a more central role in managing back pain for our patients. And so to some of Carl's points, there's a lot of inefficiencies in the way that we, at least in the US, manage lower back pain, which we're seeing evidence of in the high surgery rates, which again, for most non-specific lower back pain, you don't need surgery. Surgery is not a good option. It's very expensive and it's not effective. And so this model brings to the center of triage, essentially, someone who's trained in understanding back pain and how and who needs what. And that from some of the data that we are collecting so far. So I've been here a year and a half, and there are 4 chiropractors in the system now and several physical therapists that are specialty trained in spine. And we're all bringing the cost down, and we're seeing that progressively over time here at Duke, which is cool. When we look at now LMICs, one of the ways in other fields of healthcare that costs have been driven down is by using community health workers. And in those, there have been really successful endeavors in utilizing community health workers in managing tuberculosis, HIV/AIDS. There was a pilot trial. This was actually done in inner city Detroit recently, where 31 chronic pain patients were paired with community health workers who then guided the chronic pain patients through cognitive behavioral therapy modules. So they weren't necessarily qualified to conduct cognitive behavioral therapy with the patients, but were able to guide the patients through modules. And they saw some improvements. Now, this was just a pilot, so we can't say a ton about it, other than, at least in that study, pain intensity and pain interference scores all improved when community health workers were engaged in the process. So that's one idea in terms of cost effectiveness. Let's move on real quick because we don't have a ton of time left, but context-specific approaches to managing lower back pain. I have an idea that's hasn't really been looked at a lot yet, but has a little bit. And so I wanted to kind of pitch that. Maybe I'll do that before we open it up for other comments, if that's okay, just so I can kind of form this a little bit. Traditional healers. So traditional healers and what are commonly termed bone setters are where a high number of people in certain countries will first seek care for musculoskeletal problems. So we have a lot of data about why that is, why people might go see a bone setter. We have a lot of data on the fact that people do go see bone setters in these settings, oftentimes before they see an allopathic provider or doctor. And I'm wondering, and this is kind of how I would consider moving forward, because I think it could really help both with cost effectiveness and context specificity, but could we potentially pair from a biomedical care standpoint with traditional healers or bone setters in a safe way that would also be cost effective and context specific? One quick thing before I open this up. So that question has been started to be looked at in Tanzania, actually, with KCMC, which is pretty amazing. So this was a group of researchers from KCMC, as well as I think the lead author was from Penn. And they found that looking at, so they took patients with musculoskeletal issues at KCMC and essentially asked questions about whether they sought care from bone setters / traditional healers or not. And this is what they found. The patients at KCMC reported a much lower incidence of traditional bone setting patronage than expected, considering the majority of Tanzanians meet their healthcare needs through traditional medicine. This suggests that either patients, so 2 conclusions in their minds. One, either patients avoid traditional medicine specifically for orthopedic injuries, or the ones who sought traditional care for musculoskeletal injuries, are not actually ending up at KCMC. They opine in the latter scenario, collaboration with bone setters through a referral system could expand allopathic care access to these patients. So again, some hints of what would happen if we tried to pair together from a biomedical care standpoint with traditional healers and specifically bone setters when it comes to back pain. That's what I've got. Whatever time we have left, if any, I'd love to hear some ideas from each of you.
Wonderful. And I did put a couple of the papers that were referenced, especially that working group about what low back pain is and why we need to pay attention to it. That's in the chat if anybody wants to take a look, as well as I was very curious about this one with our colleagues at KCMC. So I put this paper in the chat as well. I wanted to call out Farida's comment about context specific, not only for the solution, but the problem, right? Farida shared that in Uganda and East Africa, for example, it's expected for women to bend instead of sitting or standing when doing chores. So contextual cultural issues need to be addressed. And Catherine's engaging there. Other thoughts, comments, questions, points for discussion? Let's see, from Bruna. Like to know if the fear of feeling pain is also addressed. Since people I know with chronic back pain or chronic pain often avoid treatment out of fear of making it worse and don't engage in physical activity. There is kind of also this, I don't know if that you would consider that a paradox, but people with some of these chronic conditions aren't able to kind of get over the hump of doing what maybe helped or maybe recommended.
That's absolutely true. In fact, there's we call those fear avoidance behaviorisms, and it's well documented that fear of movement absolutely can create a worse problem for the patient. So I think getting in at that level and I think that's why context specific is so important. And I love, Frida, that comment that you shared is so perfectly illustrative of why care has to be context specific and how do we do that. And so the fear of so we actually have a term for that, is kinesiophobia. It's a fear of movement, and that absolutely is a problem and can be addressed in a context specific way. So thank you for bringing that up, Bruna.
Well, that makes me think of, I was really intrigued by that study, the small pilot study about the community health workers. First, I hear community health workers are doing something for low back pain, and I'm thinking, what could they possibly be doing for this problem? And you mentioned TB and HIV, and I'm thinking, okay, well, if there's like a pill that's a solution, we can kind of connect them with care and get that, but that doesn't seem like the solution for low back pain. And then when I hear you say they're doing CBT, even more interesting, that because when you're talking about these issues of fear, I'm wondering, how much of the problem is the back pain itself? How much is exacerbated by some of these mental health things that can kind of feed each other? That's really interesting.
So the model we're using to understand back pain better right now is called the biopsychosocial model, because each of those are factors in the development and perpetuation of back pain. And so these modules were actually online modules in this study, and the community health workers were trained to help guide the patients through those modules and connect them with resources that they needed along the way. So yeah, pretty interesting approach.
Yeah. I think it's also important to know, Ben, you're probably aware of that here at Duke, the Department of Psychology and Psychiatry works a lot on the pain coping ideas and the fear of movement, and they work together to create the cognitive behavioral informed skills training module that is for rehabilitation professionals specifically. So everybody that works at Duke in the rehabilitation field is able to do that training and to be certified in cognitive behavioral skills without being a psychologist, so that you kind of can mix your therapy, like your physical therapy or occupational therapy, with coping skills development, activity tolerance building, education, everything that kind of helps with that fear of movement and kinesiophobia through a more like cognitive behavioral approach without having to be one. Yeah.
Yeah, on a personal level, I've seen patients co-treated with patients who are working through that with their physical therapists, and it's been hugely beneficial. So, yeah, I don't know in what way community health workers could be engaged, maybe in that as well.
Yeah.
But yeah.
Love to hear if there's other comments online. Natan, go ahead.
Hi, first of all, great presentation. I loved it. My question is more like a comment. In Brazil, we have a strong primary care approach, and we have community health agents that are from the community and work within the primary care unit. And we have those, like, how can I say this? Like gyms that are open to everyone. So there's a couple of uh, equipment that are like across the street from where you live. And the community health agents and the physical therapists and the physical educators that work within the primary care setting, the primary care unit, they usually tend to do these like events or actions that they call with what they call everyone to engage in a in this gym, that's open gym, and people would just go there and then practice exercise. But my question is more related to the people that usually go to this event or go to these gyms are the elderly, because the healthcare unit is usually open in like 9 to 5. So people that are working can go. So how can we address this with community health agents or workers when people are working in the same time?
Yeah, it's a good question. From an exercise standpoint, most of the exercises that benefit back pain don't actually require equipment. So a lot of them are just body weight based exercises, whether that's planking or dead bugs, or there's a lot of those kinds of exercises that can be done outside of really not needing any equipment, anything more than just the floor. In terms of working with a community health worker, that's a really good question. I think just with I don't know, with increased connectivity technologically, that might be a method of maintaining at least a relationship between the patient and the community health worker. But that's a really good question. I think a valid concern, and one that, yeah, as we develop some ideas, we definitely need to pay attention to. Thanks, Natan.
Thank you.
Want to add something?
Yeah, I did have going again, like when I was marketing. Just talking from the LMIC and RIC perspective, I was just thinking how much that non-traumatic nutritional deficiencies and that occupational work related gonna contribute. And that is the way, that is perhaps the point where your community health workers can play a bigger role.
Yeah, what a great, so I hope everybody heard that. So the question was about non-traumatic back pain, and especially back pain related to occupation, and a comment that community health workers could play a very impressive role in the management of those. And to the point earlier about preventing those types of problems, absolutely, that makes a lot of sense to me. A lot of what I see just clinically are people that are sitting at computers for long periods of time and posturally, like it's really bad for our spines to do that. And you don't have to be a chiropractor or a physical therapist to tell someone like how to sit and like how to change positions every half hour. Like that's something that absolutely a community health worker could do. And so, yeah, what a great point. And I think that's one way we could for sure engage community health workers to address the cost effectiveness of managing lower back pain.
Yes, please. I also see nutritional deficiencies.
Sure.
And the other thing was that is specific spondylosis. I'm not an orthopedician, and they do play, for a significant number of patients who come to me at the back when they are ultimately diagnosed with nutrition deficiency spondylosis.
Interesting.
So again, that's the same zone.
Yeah.
And workers, exercises, cultural therapy are gonna play a role and nutrition.
Yeah, absolutely. So the comment again was that another realm that community health workers could be of great benefit is in helping patients nutritionally to manage issues that could be contributing to their back pain. So thank you for making those points. Really good.
Awesome. Okay.
Someone's going to do their PT exercise now. It's beautiful.
It's always a good reminder.
Yeah.
And like sitting next to a chiropractor and thinking I better adjust my back a little bit or else I'm gonna be judged or have chronic back pain, which nobody wants. Natan added a photo of a gym. I'm guessing this is like one of these open air gyms.
Outside gym.
Yeah,
Yeah.
which are just open to the public, kind of like a park. So thanks for sharing that, Natan. And you do see these all over Brazil.
Need to copy that model, Natan. We love it. Kids love it too whenever we go. It is fun, yeah. It's cool to see also people actually using it.
Oh, yeah.
Yeah.
People use it a lot actually here in Brazil, especially here in Maringá, where I live. It was the first city that created this, and then it spread all over Brazil, and people really use it a lot. And now in Maringá, there's gonna be physical educators in every single one of them, so they would instruct and teach people to how to perform the exercises. So
You mean like
Really
professionals
nice.
just hanging out in the space
yeah,
to
like
guide people who come along? Oh my God.
yeah, public.
health
They are
service,
hired by the
medical.
public service, the healthcare department, and they'll be
Incredible.
there just to instruct how to do that because there's no point of doing these exercises if you don't know how to do it. So
Incredible.
because it can make it worse, of course.
Right.
So
That's
it's all
awesome.
free. I love it.
Of course it is. Brazil.
We have a lot to learn from Brazil. All right. Did you have any other final?
Just gratitude. Thanks, everybody. Thanks for your ideas. And I look forward to collecting those and moving forward. And grateful for the opportunity to present. So thanks.
Awesome. Thanks so much. Join us in thanking Dr. Holmes.